This conference will now be recorded.
Good evening, everyone. So, can anyone open the mic and tell me that if my voice is clear?
Good evening,
Before I
Dr.
start.
Samira. Yes, very clear.
Dr. Mustafa, can you hear me well?
Yes, yes, very good.
Actually, I cannot hear anyone. Then let me stop my recording here.
This conference will now be recorded.
Okay, today we will be discussing about part 2 MRCOG exam. Now it's a dream for many people to pass this exam, MRCOG as a whole, and I always consider part 2 as a way towards part 3. So your goal is to pass part 3, right? And while you are preparing for your part 2, it should be in your mind that you will appear and you will be going for part 3. So your preparation should be based on not only to pass part 2, but also for part 3. Now, why I am saying this? There is an importance why I am saying this. Because if you are concentrating on part 2 only, you will try to find shortcuts. By shortcuts, I mean you will think what is important for the exam, what might come in the exam. I will read only this talk because they're asking a lot about it. I will read this guideline only because they're asking a lot from this guideline, and I will cover only the important points because they are mostly 60-70% they are asking from these guidelines, from these talk articles. Now you can pass by this strategy. I'm not saying that you cannot pass by this strategy. You can pass, but the problem is even you can pass from the first attempt by this strategy. It's a very good strategy. But the problem will be in part 3. You will stuck in part 3 because the syllabus, they need to cover the syllabus for the things which are which they ask you already in part 2. They will try to cover the rest of the things which are not being asked in part 2. So they are trying to cover the syllabus, and they combine part 2 and part 3. So it will be very difficult to pass part 3 in first attempt with this strategy. And what you have to do, you have to go through all the information, all the knowledge again from the scratch in order to understand and in order to pass part 3. So why don't you put all your effort reading for your exam for part 2 so that you don't have to suffer for part 3. For part 3 there is 70% passing rate. All of you knows, right? Whoever goes for the exam, 70% or more than 70% will pass. So there is a very high chance of passing from the first attempt, only for the people who put their effort in part 2. So the question arises, for part 2, how many months is enough to prepare for part 2? The answer is, it depends. It depends what? Maybe you are not working and you are sitting at home, and you are not very busy at home also, and you can give like 12 hours per day straight, so then 6 months should be enough. If I will say less than 6 months, 4 months is enough for the people who are going for the exam first time in order to pass the exam. Not seems to be practical. I don't think so. Even if someone is extra genius, I don't know, but usually for people like us, it requires at least 6 months. If you are working and you have family and you have other things in your life, for sure, for most of the people, then you can extend it to 1 year. So between 6 months to 1 year. Let's start my slides. So can you pass in first attempt? The percentage of overseas students passing in first attempt is less. It is not more than 15%. I don't think so. So, and why it is so? Yeah, low chance of passing part 2 in first attempt. Because first of all, you are not prepared well. You know, people just attempt because they want to see how the exam is. But the problem is, nowadays you don't have to see how the exam is. Before, I attempted the exam just to see how the exam is and how the questions are, because I was blind. I was not in one of the Telegram group. The information was not like this. Now the information, there is a lot of information from the Telegram groups, from the Facebook groups. There are a lot of mentors like the one I have, Dr. Mustafa. Welcome, Dr. Mustafa. Thanks for joining. And we will be talking together, right? So there you have a lot of mentors. People are giving free sessions, a lot of free sessions, a lot of mock exams, a lot of EMQs and MCQs. Sorry, a lot of EMQ discussion and SBA discussions, a lot of topic discussion. So you are lucky. No need, now you can pass in first attempt. Before, maybe it was very difficult. So first of all, you should attend any theory course. I'm not saying that you attend my theory course, but you attend any theory course, because for the first timers, and there is one more thing, that if you think that you uh, you can, there are many Telegram groups. If you are in many Telegram groups and you are gathering information from here and there, you can have an idea, because there's a lot of information, but your idea will not be structured. So I recommend, highly recommended, to attend a theory course, because it is a structured program, structured 6 months course, for example, in which they will tell you how, in a structured way, targeted, focused, and student-centered way. Student-centered because everyone is individual and has individual requirements and needs. Every brain is different. Okay, so I highly recommend to attend a theory course. Now I went to UK and to attend courses, but I didn't attend theory course much. But to tell you the truth, there were not much theory courses at that time when I was giving the exam in 2015. There is, but you know, I was discussing with my friend, with my study partner. Now your study partner is very important, and we will come to it. Now, secondly, and I attended one course of Dr. Asma. She's still, she was the first one online course that she was offering at that time. And now how many people are offering the courses? I mean, a lot of choices, right? So she gave me structure. I had no idea of how to approach this exam. After I have this structure, I did not pass from immediately the next exam. I passed 2 exams after that, which is fine. But I have a structure in my mind. I was not ready. It's not because she didn't taught me well, because I was not ready. But I had a structure in my mind. This is one thing. Okay. And commitment, of course, all of you, I believe, are committed to pass this exam. No one is joking over here, right? And you have to, even if you are working, you have to dedicate like 5 to 6 hours study. It's not a strict rule. If you cannot study one day, just next day you study more, because not all the days are same, which is fine. And you have to arrange your life, your kids, and everything. And you have your family support is very important. It is not possible without your family support. I will say not possible. So it is really very important. Okay. And you have to sacrifice also a few things. Maybe you need to sacrifice your vacation, and you need to be punctual. Now, how to do revision before exam? Can you do revision in 2 weeks? Can you do revision? Some people are, even when I was going for exam, I heard from many people that they can revise all the material in 1 week. So I was really impressed, at that time, that how people can revise in 1 week. And then later on, I realized I didn't revise in 1 week. I revised all my material in 10 days. But I realized later on that it is possible to revise all the material in 10 days at least, or 1 week for some people, or I rather say 2 weeks. Let's say 2 weeks. So everyone can revise in 2 weeks. I revise in 10 days. Some people revise in 1 week, but everyone can revise in 2 weeks. Okay. So a day before the exam, I will tell you how to revise in 2 weeks. But 1 day before the exam, there are many things that people fail in exam, not because some people are very well prepared. They are prepared well for the exam and they could have passed the exam, but they will not pass because of some of the mistakes that they would have done or they will do. For example, 1 day before the exam, they are reading and they are trying to grasp information from here and there, opening many things, like panicking. So 1 day before the exam, you need to relax. You might think that I don't remember anything. It's a normal feeling, which is fine. You will remember when you will go inside and the question paper will be in front of you, you will remember. So don't panic. First of all, once you prepare well and a day before the exam, you stop and maybe watch any movie, talk with your family, go out on dinner, do anything to relax, go for a walk, but don't read before 1 day before the exam. It will give you stress and anxiety, and stress and anxiety might be the reason of failing the exam, not because I have seen people who just become blank and they cannot see anything. One of my friends, she said, I just became blank and her eyesight is fine, but she cannot see anything because her mind was not working. Yes, of course, everyone can get the recording. So her mind was not working. So it's very important not to read 1 day before the exam. And what you have to do a day before the exam: sleep early, try to sleep early, wake up early, well before the exam, eat light breakfast. If you have a tendency of having headache like me, I used to have migraine, so I took paracetamol prophylactically. So it is fine. No need to take more than this. Maybe if you don't have the tendency of this headache, then don't take it. But at the end of the exam, I used to have headache, so I will say, okay, I will take it prophylactically. Okay, so it's a good. There's a scientific reason of chewing a chewing gum, and it will increase the blood supply of your brain. So keep on chewing a chewing gum. Of course, at the end of every exam, you will throw that one and you chew another one. Just a small tip, very silly thing, maybe it seems like, but I saw the effect. I experienced it worked. That's why I'm telling you. So, um, and of course, you will pray before going for exam. If you will take a shower, you will become fresh. Your mind will become fresh with a light breakfast. And you don't have any anxiety. You have to think, what maximum can happen? Maximum, I will not pass the exam. So what? I can go for another time. For me, I did not pass in first attempt. And here I am teaching you. So it doesn't matter. It will not be written in your certificate that how many times you attempted part 2. So relax. There's no need for anxiety. There's no need to panic. You have to do, if for the people who are going for the exam 2-3 times, 3-4 times, they are not passing the exam, they have to think what they are doing. And they should be doing something different this time. It must be something wrong, right? And you have to recognize what you are doing wrong and then act upon it and do something different this time. Okay, you are reading from the guidelines, talk articles, maybe strategy, some information from strategy, and your information is good, your knowledge is good, but you can still not pass the exam because you don't know how to attempt EMQ and SBA. It is a skill how to attempt EMQ and SBA, right? SBAs are straightforward, but I must say EMQs. To understand how this EMQ works and to understand how to attempt this EMQ and pass the EMQ is a skill. That is a learned skill. Everyone can learn it. You can learn it also. Some people learn it from the first time, some people learn it after 3 times, but the thing is that you can learn it. Okay. So, you have to go module wise because you have to cover the syllabus. Of course, there are few things from the syllabus that are coming, that are recurring, that are coming frequently in the exam. They will ask many times about labor from the intrapartum guideline. They will ask many times about operative vaginal delivery. They are asking about, for example, from the surgical point of view, from about the prolapse, wall prolapse guideline, 3rd and 4th degree, perineal tears, genital mutilation. For example, there are some topics which are they're asking. I'm not saying important topics. All topics are important, but they are asking frequently. So you should know which are these topics which the college have in their mind, and they're asking it frequently. For them it is important from the exam point of view for part 2, but they might have the other topics in their mind which they will ask for part 3. So all topics from the syllabus are important. There is nothing important and unimportant. Everything is important, but you need to know for part 2 what is in their mind, what they want from you, and they're asking frequently. And how you will know this? How you will know this? By doing recalls, more and more recalls. So you have to be involved with your study partner, with one of the mentors, like me, Mustafa, Dr. Gada Badran. I mean, there are very nice, good mentors. So you, Dr. Hala, and all of them, Dr. Raba. So any of the mentors, you can join, no problem. But recall, discussion of recall, more and more discussion of recall. It is very important, and I will tell you why. Not to lose hope. This is very important. Believe in yourself and you can do it. Of course, you can do it. If I can do it, and if many other people can do it, I never worked in UK. There was a wrong conception that the people who are working in UK or who did attachment for few weeks, for few months, they are the one who can pass exam easily. But nowadays, overseas students are passing exam, maybe not from the first attempt, but they can pass from second, third, or fourth. Who cares? I mean, it will not be written in your certificate that you pass from first or third attempt. Doesn't matter at all. So this is for the July. This course which I offer is for July candidates. And usually what I'm doing, I just want, because many people are asking me, just give me 5 minutes to explain how I work instead of telling individually. So this is for the July, right? It's a 6 months course. Like I'm almost finishing a course, which is actually I finished it, which was supposed to be for the January exam. but very few people are able to go for the January exam. Most of them will go for the July. This is another thing. Because of COVID, many things postponed, and a lot of disturbance happen. So this is for the July. So what I do, I go module wise. I'll show you and that I combine some. There are 14 modules and I combine some of the modules. So I will take one module like urogyne, like fertility, like operative procedures, for example, pre-op, intra-op, post-op, the surgical module. Then I will send the pre-module, the pre-session material, all the talk articles, and the guidelines about it. And then during the session, it will be like a 4-hour session. It will be for two days, because you cannot finish all one module in one day. If you want to cover all the talk articles related to it, if you want to cover all the guideline related to it, then you need 2 days. It means 8 hours. It can be 7 hours, 6 hours, I'm not saying, but maybe 6 hours in one go. I don't have stamina to talk for 6 hours. Some people can do it, but I cannot. So I maximum can talk for 4 hours. Okay. And then after the module, you will be given like questions, like a mock questions to solve. And then after that, at the end of the so it's an interactive. I make questions from the guideline and I ask people. It is recommended to read the guideline and talk articles before the session, but even if you don't read it, just go through it very fast. It will be very easy to answer the questions which I am asking. Yes. So there is a crash course. This is for the students who are going for January exam, and it is my recall discussion, which I am doing recalls. Now, let's talk about the exam. Just give me 2 minutes, and then I'll come to the modules, how you can summarize these modules in 2 weeks. And I'll give you examples how you can do it, how you can read a guideline, and how you can read a talk article in one guideline in 5 minutes, one talk article in 2 minutes or 3 minutes. This is your maximum for revision, right? Because you have a lot of guidelines and you have a lot of talk articles. Yeah, you can do it, because I did it. Not from the first time. It seemed impossible for me, but that just before I passed my exam, the attempt in which I passed, I was able to do it. So you know from your revision that you are going to pass the exam or not. Okay. So everyone knows here who are going for the exam that there are 2 papers, each 3 hours, and there are SBAs and EMQs. Now the exam is like from the Pearson Center, and my students who went for the last time, they are saying it is actually don't panic. It's more simple. You just need to click, and the one you are in doubt and you will leave, it will come at the end for you. And so it's not difficult, it's actually more easy. And you know how is the EMQs and SBAs. Now these are the modules and you need to cover all the modules, but you can combine these modules for revision. Like, so if you divide 7 modules in 14 days, it means you combine module 1, 2, and 3. You can combine clinical skills, teaching, clinical governance, research. I mean, you can combine easily these 3 things in one module in one day. And then what you can do, combine 5, 6, and 7. Let's see what's 5, 6, and 7. These is all about surgical procedures. Like I told you, 3rd and 4th degree perineal repair. So you can combine surgical module in World Prolapse Guideline, for example, genital mutilation in one day. There is no problem. Okay. And then you can combine 8 and 9. Like about obstetrics, antenatal, and maternal. But this one is separate. you can combine 10, 11 at least, intrapartum and management of delivery, including term delivery and pre-term delivery and all kinds of presentations, everything VBACs, everything about delivery you can combine. And postpartum problems you can combine because there is PPH, uh, purpural pyrexia, and not much sepsis, postpartum sepsis, for example. There's not much about purpurum, so you can combine it with the labor intrapartum. Then 14 and 15, you can combine modules, um, subfertility and sexual and reproductive. You can do it separately, like subfertility you can do separately, and the people who have attended my session for subfertility, they know exactly what I mean. You can, it was a 4-hour session, and I covered guideline and almost all TOG articles, not 100%, but almost. So you can, if I can give you a session in 4 hours and you can listen and understand, it means you can do your subfertility in 4 hours also. If not 4 hours, do it in 8 hours, 6 hours, but you can do it. So if the idea is to have summaries, now how do you, are you depending on me to make summary for you? If you are very busy and you don't have time to make summary, I can do it for you. I have done it, no problem. But the thing is, you can do it for yourself also. And how to do it, let's see. And then you can combine like 15, 17 and 18 are separate. Combine 13 and 16 actually. 13 gynae and early pregnancy care. This is very important. RCOG is in love with the early pregnancy care and they're asking a lot about it. And intrapartum, they're asking a lot. Actually, there are few things or few guidelines, few talk articles which are coming frequently, and they're asking a lot of questions from them. And while you will be doing the recalls, you will understand what I mean. That which are the topics which are important. You can make your own important topics. You don't have to depend on anyone. Just attend what is important for you is to be targeted and focused, not on the things which are coming for the exam, to gain knowledge so that you can pass part 3 after part 2. So this is important. So 15, 17 and 18, you can separate this one. Oncology is separate and urogyne, because there are a lot of talk articles about urogyne, a lot actually. So you can separate it. So you can do it in 14 days. Why not? Let me give you an example. For example, this is a clinical governance, and this flower like structure is from the strategy. Let's take one guideline, clinical governance guideline. I took a difficult guideline which not everyone is reading, just to let you know that these clinical governance, there is nothing to leave from any part of the RCOG website. You have to in order to pass the exam, you have to keep
Just
an
to
idea
let
and
you
read
know
even
that these
clinical
clinical governance,
governance
there is
guidelines.
nothing to leave.
For example, in this guideline, what you need to know, that what is the definition of risk management is a tool for improving the quality of care. If you know this, that's it. This is the first point. Second point is incident reporting. And what is important from the examination point of view for incident reporting? The triggers for incident reporting. And there are two ways of incident reporting. One is reactive and the other one is proactive risk management. Fire drills is one example of proactive risk management, like shoulder dystocia, fire drill. For example, this is okay. Let's see what is important from the examination point of view. Now, this table is important. It means what is risk? You have to identify the risk first, then do the analysis, treat it, and then control it. You just need to understand it. And how you identify the risk, these are all from the guidelines and from the complaints, internal and external sources. This is will not come in the exam. This is for you to understand. Okay, what is a root cause analysis? You need to understand what is root cause analysis. A root cause analysis, because if you are doing incident reporting, you should know what is root cause analysis. You have to identify the incident, select members of the team, gather data. Now this one is important for part 3, but you are reading it in part 2, like how the fishtail diagram works in root cause analysis. Um, now what will come in exam is this. Now it seems a table, right? This is table number 3 and this is table number 4. But let's see what is table number 3. The trigger list for incident reporting. And now what RCOG will do, they will take one incident like, for example, FGAR score, or they will take COT pH, for example, and they will create a scenario out of it. For example, how to create a scenario from this COT pH less than 7.05 arterial or less than 7.1 venous. For example, they will tell you that there is a, for example, a cord prolapse. She progressed by herself very fast, and she delivered a baby girl, and the cord pH was, arterial pH was 6.9 or 7 exactly. If they will say 7, it is 7.0. Okay, so this is the cord pH. Is it a trigger for incident reporting? Can anyone answer me? Now the answer is in front of you. I'm pointing you the answer. Now can anyone answer me? I'm just creating this EMQ. It's not in the recall, but this is how they are asking. After doing many and many recalls, I can create my own recalls, and you can do it also. Okay, so if the cord pH is 7, is it a trigger for incident reporting?
Yes.
The answer is no.
Oh.
Yes, Dr. Sarah, what you are saying, because I'm pointing you here. Please concentrate on the details. Now, after doing a lot of recalls, after discussing a lot of recalls, I found out that the RCOG is very fond of talking about cutoffs. So when they write less than 7 is 6.9. Now I'm showing you, and you are reading in front of me. It is in front of you. I'm showing you, I'm pointing you, but many people are answering it wrong. So it's not only that how you read the guideline, it is how you understand or how you interpret. Usually exactly 7 you can say, but usually exactly 7 no need. Less than 7 is needed. Less than 7. If you will say 6.9 something, yes, you need to report it. For example, this one is very clear. Less than 7.1, 7.0, you need to report it. This one, they bring it for confusion. But if it is 7 or more than 7, then there is no need to report. If they are specifying you that it is 7.06, for example, then no need to report it. If they're specifying you that it is 7.04, then okay, you will report it. If they specify you, yes, but you should know one figure like 7.05. You should know this figure, and you should have in your mind that what is given in the guideline is less than 7.05. If they specify you 7.04 or 7.06, then you answer accordingly. For example, FGAR score less than 7 at 5 minutes, and if the baby's FGAR score is less than 7, which is like 6.9, 6, for example, then of course you need to write incident reporting, and not in 1 minute, in 5 minutes. So if you remember less than 7 and they will say in 1 minute, the answer will be wrong. So it is for 5 minutes. So in 5 minutes, if it is less than 7, in 1 minute, if it is less than 7, it is not a trigger for incident reporting. But in 5 minutes, if it is less than 7, then it is a trigger for incident reporting. Just, they will try to trap you. This is not their idea of trapping you, but they want to tell you exactly when to write the incident reporting. And for example, this one. This is for the trigger list for gynae. For example, ureter injury. You will report, right? Any damage to structure is an incident for trigger for incident reporting. For example, if failed sterilization, failed termination of you are doing termination of pregnancy and it failed, you need to report it. Now I'm giving you an example here. For example, you are they might ask you that you are doing termination of pregnancy of a class C abortion, according to class C abortion act, for example, and later on the patient still feeling the pregnancy symptoms, and you do the pregnancy test, you do the ultrasound, you still find products of conception, for example, then of course then they will not give you like how it is given here. They will create a scenario out of it, like they will create a story, and then usually the EMQs are from the real patients in their hospitals who are coming, and believe me, patients are same. Either they are British patients, Irish patients, Arabic patients, South Asian patients. The anatomy and physiology and pathology is the same. So the same patients you are seeing in your hospital, they are seeing also. The only thing is how they manage and how they approach it. I realized that they are asking from this table. This is from the same guideline, right? So what are the two tables? What are important in order to cover this guideline? This table and this table. That's it. If you cover from this guideline, these two tables, it means you cover for part 2. Now you should know, they will tell you now, for example, they will ask you the risk of having ureteric injury in laparoscopic surgery or hysterectomy, for example. Is it common? Is it uncommon? Or they will say that it is 1 out of 1,000. So they want to know that if you know that between 1 to 100 to 1 to 1,000 is uncommon, so you should know these figures. This is important. How I know that they are asking it? Just simply by doing lot of recalls. I know that uh, they are concentrating on these two tables from this guideline. How much time? This one you need to print it and keep it with you and create more and more scenarios with your study partner, and so that you can understand, right? So that you can answer any question from it, because there are a lot of scenarios that can be made from this. So if the baby is born and if the baby is 500 grams, 500 stillbirth and 500, are you going to report it? Is it a trigger? Yeah.
No,
Yes,
This is
yes,
what I'm
no,
saying.
this
no,
is trigger.
no,
Yeah,
no,
The answer is no.
more than 500.
I'm telling you repeatedly that please concentrate on what is written over here. So what is written over here is not without a reason. It's for a reason. And they are very fond of concentrating on the cutoffs. More than, less than, more than or equal to, less than or equal to. Concentrate on these things. Learn. You just write it somewhere or print out. Just try to remember. For example, there is a consent advice, clinical governance advice number 6, obtaining valid consent. I don't know, have no idea, but this is what I find out that they want to confuse us maybe. Uh, but and they want actually they want us to be very perfect, which is fine, which is fine. So what is important from this guideline that you should know that what is Gillick ruling, and they might say 15 15 and a half years or 15 years old girl, and you should know the definition of minor. If you don't know the definition of minor, then you cannot answer this question, right? So in this guideline, this is just copy and paste, right? So those under the age of 16 years of any age who are able to understand and who is proposed and have sufficient discretion, like they are competent to consent for medical treatment. Even minors can, if they are competent, Gaelic competent, they can consent for the medical treatment. Now, once the age is 16 years old, so you see, under 16 are minors, and someone needs to evaluate them that if they are competent or not. And there are 4 points in which how you can, judge that if they are competent or not. But at 16 years, they are presumed to be competent. No need to do test of competency, right? Okay. Now, for example, this is a minor. They might give a scenario in which a 15 years old girl is going for, she has ovarian torsion, for example, and she's going for, and she refused treatment. She doesn't want to go for surgery, right? She's a minor, right? She refused treatment. They might ask you, her mother, because her mother understand and she was instructed by the physician that her life is at risk, and it's an acute abdomen or blah blah blah, whatever, they will create a scenario. So a mother can overrule that decision or not. Now the answer is written in front of you, but still I want to know from you.
Can overrule.
Okay, Dr. Mustafa.
Yes, she can overrule.
She cannot refuse it.
She can.
Yes, Dr. Mustafa, are you there?
less than 16 years can mother take consent. Yes.
Mother take consent. Yeah, because it is written right in front of you. I'm
Yes,
showing you and I'm pointing you, but still some people are giving me wrong answer. Why? Because sometimes you are reading it, but you are not interpreting it, you are not getting it. That's why it's important to read with someone like you, or maybe some of the mentor, read guidelines with them in order to understand. This is not for the revision, but I'm telling you what is the important points in this guideline. Okay.
at 16 to 18, deal with them as adult. More than 18, adult. Less than 16, less.
That's
But yes, should we consent our mother or father include?
yes. So
Less than 13, less than 13 in
Mustafa,
UK.
they can create a lot of scenarios out of this Gillick competency, right? A lot of scenarios they can have.
In recalls only.
Yeah, how you will know? How you will know that how to answer? Because how you will know that how what is in their mind? No one can know what is in their mind unless you are. Recalls are very important for me to discuss. Now you must know what are the key principles for consent, valid consent. Patient must have capacity to make, and this is talking about an adult. Patient must have capacity to make an informed decision. 3 points. It is written in the guideline. Consent
Yes.
must be voluntarily. Third point, patient should be fully informed. Now, this is
We have many, yes, yes.
yeah, these are 4 points of a competent person. How you know that the person has capacity or he or she is competent? There are 4 points that how you will know that she is competent. She understands, she retains, she decides, and she communicates. Now I have this in my part 3. One of the question was related to this. So if you skip and no one asks you this time, they will ask you in your part 3. So this is important to, yeah, Mustafa, you were saying something?
No, continue, please.
For example, what is important, and I find it frequently they are asking for gynae exam, what kind of consent is it? First of all, a consent is needed or not?
Yes, needed.
Yes, of course. So, and a chaperone is important. Either you are a female practitioner, physician, or a male practitioner, but chaperone is needed for every pelvic examination. Now, Mustafa, do you remember they are talking about verbal consent, written consent? They're asking, right? So, which of the things that written consent is must? There are very few things in which written consent is must. In case of emergency, for elective, of course. What is the problem? You can give written consent, you have a lot of time, but if talking about emergency, for example, I remember one question they were asking in emergency cesarean. Now I want you to answer, any one of you. So in emergency cesarean section, cord prolapse, they create a scenario, right? Cord prolapse, CTG with bradycardia, you are taking the patient, you are rushing the patient to cesarean section room. You forget to take the written consent. Now they will give you a lot of options. I actually forget what kind of what were the options. They might give you options like, is it from the legal point of view, are you to be held responsible, you will be punished, or should you take the consent from the husband, or whatever, I mean, so what you should do, can you take the patient for cesarean section without a written consent? Can anyone answer me?
Yes,
Yes,
yes.
that is true. You can. You can take the patient in emergency cesarean section, but you
And then
need to write it in detail. What was the reason in your notes? That what's the reason why you didn't take the consent? You can write it retrospectively also, and there is a way of writing your notes, but you have to write it in your notes that why you did not take the written consent. And if you write it, that is fine. So for gynae exam, for example, verbal consent is more than enough. Like for breast examination, there is first of all, there is no need for routine breast examination in a pregnant woman and even in a gynae patient. But if the patient is complaining of galactorrhea or something or whatever pain, then you can. But verbal consent is in the presence of chaperone is more than enough. Now they're asking a lot about this unexpected pathology. How many questions for unexpected pathology? For example, you are doing ovarian cystectomy, and
Many questions and repeated recalls in
very
every
many
recall.
questions. Can
And
you remind me, Mustafa? You are
pathology.
younger than me, and you will remember. What is one of the questions that came about
Patient
this?
example. Patient consent for appendectomy, and you suddenly see ovarian cyst in other side.
Hmm.
You
Yes,
will
yes.
call gynecology doctor.
Yeah.
Example. Second point, if you see example simple ovarian cyst, but you see other structure, what you will do next step. Many questions here. You consent patient for left side. You saw in right side. Yes.
Yes.
Also about the general BV exam, if you will do under anesthesia, should be written consent. But
Yes.
simple exam, no need. breast examine no need يعني verbal exam
Yeah, there was
verbal.
one question I remember, that if you are doing examination under general anesthesia, PV examination, that then you need a written consent. And all this information is there, Mustafa, in the guideline. For example,
Yes,
I'll read it for you.
written everything in guideline. Green
Yeah.
top guideline first should be
Yes.
no.
Yeah, that's true. So for the consent, for example, such as endometriosis, maybe now there is a rule of thumb that if you take a consent for something, and if you find something else, even if you suspect that it is cancer, you will not take it out, and you will close the abdomen. If you are doing appendicectomy, you do appendicectomy because you have taken consent for appendicectomy, and you will not touch the ovarian cyst, even if you suspect that this is cancerous. Do you remember, Mustafa, they were asking, should you take the biopsy from the ovarian tissue, even if you suspect a cancer for
Doctora,
this ovarian cancer? Yeah.
in last 2 year money change. I will give you example. Patient consent for appendectomy. First example I will tell you. But appendix normal. But you see other pathology. You will do appendectomy or not. In TOG written clear, you do appendectomy. Even normal. First one. I share this one in group. And
Yes.
in update my recall, I will share later on, written
Yes.
this one with evidence. Second point, if patient also, now in 2020, we have, if you suspect other pathology, example, teratoma, example, no cancer, and patient consent for appendectomy, and you see you do ovarectomy for this, even not written consent in a new guideline. I will send in the group, inshallah.
Yeah. So it means that
This
we
is
need to
new. This
combine
is
these two
new.
guidelines.
This point new.
This is new, yes, for sure. Although they
Yes.
didn't ask before, but they might ask it in the coming exam.
Before don't touch. Before don't touch.
Yeah. So why,
Maximum
Mustafa?
you take.
Do you
Maximum
remember
you take biopsy.
we were discussing in our group why we will not do, why to do biopsy of suspected cancer if you have not taken the consent, or shall we do biopsy?
Almost, if you suspect malignancy, you take biopsy. Now sometimes you do, dependent of situation and written clear, if other pathology, but no dangerous for patient or no more complication for patient, you do ectomy for cyst. In 2020.
Yeah.
Also, I
But this
listen
point
one
was a
monitor.
little controversial, that whether you will take the biopsy or not, right?
Biopsy you do, no problem.
But what is the problem? I was saying, why not to take the biopsy? I mean, what possibly can be the problem, although it is not written clearly anywhere?
Now also we have a new point. If torsion, patient consent for anything, but you see in patient torsion, you do retorsion. You do. Don't exist.
Yeah,
New guideline.
you know,
New talk.
I want to say something.
Torsion.
In this same guideline, I did not copy and paste, but we discussed this point, Mustafa, that we will not take the biopsy. And I was discussing for, I remember, if any of my student is there, I don't know, there are. So we were discussing for 10 minutes actually about this point, that shall we take biopsy or not? And then it was written in the same guideline, and I showed them that we should not take biopsy without consent. You know, Mustafa, it is written in the same guideline. And I showed
Yes.
you at that time, you were not there.
But Dr. Tom in RCOG,
Yeah.
many times he told, take biopsy.
I know. No, but we need evidence, right? Because I will tell you something. I
He worked
respect
with
all the
the Royal College.
professors. I really respect all professors, all my professors, even and even now I respect all of my mentors, even who are like me. But with all the due respect, for me also, don't believe in me. Just ask me, show me the evidence.
Oh,
So it should be written, you know, written
yes.
concept.
Evidence very important.
Yeah, so you need evidence for everything. And I showed you last time the evidence, and it is written in the same guideline. I don't know where it is, that you should not take the biopsy. Although logically, we will say at least we should take the biopsy. It might help the patient, right? There is a
Yes.
tendency for this, but actually it is not written here, so we should not take it. It is written that for biopsy you need a written consent. Now, for example, this one is written in the guideline, like consent of women is required for the presence of students during, this is a verbal consent, right? During gynae and obstetric consultation, like you are sitting in an OPD and the student is sitting with you and the patient comes in, you will take consent from the patient that I have a student sitting with me. If you don't mind, do you mind? Shall we discuss? Shall we continue? Do you mind? So, or you can ask if you don't mind. So you have to take a verbal consent. Even if some observers are coming in operating theater, they are not touching the patient. You need to inform the patient from before. And of course, during gynae outpatient pelvic examination. But you see, specifically they are writing here, written consent must be obtained for pelvic examination of anesthesia woman, and I'm not making it from myself. It is copy and paste. Yeah, the consent should be verbal or written. So it is written in the guideline that it's a common misconception that consent has to be written for it to be valid. In fact, consent must be written only when the law requires it. For example, in gynae and obs is in relation to the storage of use of gametes. For use of gametes, of course, there are some things for which written consent. For sterilization, there was one question of sterilization. Do you remember that if it needs yes, it needs a written consent from the patient. And I think the validity of the consent is for 1 month, and you need to renew the consent if it is more than 1 month, something like this, although it is not written here. And then, for example, there's a guideline about understanding audit. What you need to know is one of the diagram. Sorry, I forget to bring that the definition and the diagram of audit. It is not coming in part 2, so I didn't bring it. It's now responsibility of consultant on call. What is it? I'm bringing not green top guidelines. I'm giving you example of clinical governance and good practice because we don't concentrate on these guidelines. But you should know what to read, what is important from this guideline. And I will show you an example of an IUGR guideline also, which is very common, that what to read from this guideline. But just see, I found that they were asking from this guideline, they were giving a scenario in which they are saying that there is a, for example, 5,000 births. There is a maternity. There is a hospital in which there is a 5,000 births per year. So they were, I think they were asking about the consultant cover, that it needs a 60-hour coverage or it needs a 98-hour coverage, and how many specialty training are required in this kind. So it was written over here. I found one recall something like this. Or for example, 4,000. 60-hour coverage is enough. But for more bigger and bigger institution where there are more deliveries, maybe 98 hours. And if it is 6,000, 168-hour coverage is required. If more than 6,000, then of course 168 and more. So, you know, they were sometimes asking things like this, which is very strange. Anyway, this is very important. They are asking this, and this is from this guideline. I was thinking from where they bring this. Then I find out, okay, this is from this guideline. They are usually asking from the guidelines, from the TOG articles, and sometimes from the other sources. Like, of course, you have to read Faculty of Sexual and Reproductive Health, and sometimes you need to open your NHS site. Sometimes you go to strategy, some points are there. So mostly it's guidelines and TOG articles. No one can pass this exam without reading TOG articles. They are asking more than 50% from TOG articles. And we are just discussing about guidelines, but I'm telling you that 50% at least, they're at least 50%, they're asking from TOG articles. Do you agree with me, Mustafa, regarding TOG articles? What percentage? This is what I feel. There is no rule, and it's not written anywhere, that in order
I
to
don't know
pass this exam,
about talk.
TOG
I don't.
articles.
No, I know Green Top guideline and nice more
More than 50%.
important.
What is the percentage of TOG articles, do you think?
Green Top guideline and nice more than
Mm.
60.
Mm-hmm.
Recall it 20.
Mm-hmm.
20
Just
talk.
forget about recalls, because recalls are coming from somewhere. So what is the content? I mean, from where they are bringing? You mean 30% from TOG or 40% from TOG? This is what you think?
I don't know sure. 20, 30.
Approximate. Yeah, you are saying that maybe 30%. Okay. For me, it looks like 50%, but it might be less than 50%. Yes, guidelines are important. And more than 50%, I agree. More than 50% is from the guidelines, from all guidelines, not only Green Top. Green Top is one type of guideline. There are many guidelines. But 50% or 60%, 50% to 60% is. Do you think that if you read only 50, 60%, you understand it well and you are able to pass the exam? This is the problem, that even if you have done the guidelines very well and you have done TOG articles superficially, then it is still difficult to pass the exam, because even if you have read the guideline, once they are giving the questions, you can do mistake. Even if you have read this guideline and you know it and you think that you know it very well, but you can give wrong answer. So don't depend on knowledge of guidelines only. This is what I want to say. In order to pass the exam, um, you have to go through TOG articles. And now I will tell you how to go through TOG articles. For example, I'm just showing you the example from this good practice. What is important? You can finish the whole guideline in 3 slides. Like, they can create a scenario. For example, you are doing cesarean section for major placenta previa, and they might ask you that your consultant call you that he cannot come, or he is very far away. You can start cesarean section and it's a major placenta previa. For example, they can create any scenario. So you should know that the consultant should be there, attend in person. Whatever the level of the trainee, maybe the trainee is ST6, for example. Whatever the level of the trainee, but the consultant should be there, should attend in person. It doesn't mean that he will do the cesarean, it just means that he will be there. it is not saying that he must be scrubbed, but he will be there inside the OR. So he should attend in person. Attend in person, you should understand what's the meaning of attend in person also. So the trainee might do the surgery, it is perfectly fine, but either he should assist or he should be there unscrubbed in the operation theater room. It's okay, no problem. But he should be there around. Okay. So they can create any scenario out of it, and I found many from this. Few, not many, few of them. Like in obstetrics, these are the things in which attendance in person for the procedures listed below, the consultant should attend in person or should be immediately available. If the trainee is assessed and signed off by OSET that he can do this procedure. But still, the consultant should attend in person or should be immediately available. For example, they might give you a scenario in which there is a cesarean section at full dilatation. A trainee can do it. The answer is yes. He or she can do it, but you should inform your consultant so that if he is like living 10 minutes or 5 minutes away and he can come, is readily available, or he's just sleeping upstairs, no problem, readily available, should be immediately available. If especially the trainee is not signed off, then immediately available, that once maybe sleeping in the hospital, no problem at all, but he is immediately available, like within 5 minutes he can come, right? Immediately available. So cesarean section at full dilatation, cesarean section of BMI more than 40, cesarean section of transverse line. I was thinking from where they are bringing these questions. Like if you are going for even diagnostic laparoscopy, any laparotomy, you are going for exploratory laparotomy, the consultant should be immediately available, especially if she's not signed off by OSETs. Or the consultant will attend in person. This is very good. Even if he cannot attend, should be immediately available. In preterm cesarean section, especially the cutoff is 32. Concentrate on cutoffs. BMI more than 40. Cesarean section less than 32 weeks. Just concentrate, because I pointed you out. Whenever you see a figure, you concentrate on it. Now, for example, you should know they might give you a scenario of S bar, but they will not write this term S bar. But they will give a scenario, that they will give a situation, and they'll give you a background, and they will ask you what you need to do in this situation, what should be the recommendation. For example, you should know what is S bar from this guideline. From where you will know? From good practice number 12. Anyway, let me give you a very common guideline. This is the common guideline, right? For gestational age. So if you are revising, you are doing revision, right? What you need to read, what you need to know from this guideline. Revise only Appendix 2 and this one, Appendix 3. And what is Appendix 2 and Appendix 3? Mustafa, do you remember that they are asking a patient who is 36 years old, for example, or no, they were asking a woman who is 40 years old or 41 or 42 years old. Yeah, these are risk factors. So they want to know, do you remember, do you know the minor and major risk factors and what you have to do? So if her age is, now I want to ask you something. If a woman age is 40 years old, exactly 40 years old, then what you should do? The options are, I mean, you are going to, so you, first of all, you should know what is this a minor or is this a major? So is it a minor or major risk factor?
Is 40 is minor. Is
Minor.
40
Major,
is minor.
one. Minor. Should
More
be
than
more
40
than
is
40.
major.
More than 40
40.
major.
Yes, 41.
Should be more than 40.
Yeah, please. So how
Please,
you can
please.
still answer me? I'm telling you many times, just concentrate on what is written there.
A
The
recall will be 41-year patient age.
the recall was
Or
41 years, says
yeah,
41, right? For sure,
yes.
41 is a major risk factor. So there is no doubt. But they might give you a woman who is 40 years old, right?
Mhm.
You
But
never know.
if even written 40, minor, because written clear more than 40.
Yes, that is true. This is what I'm saying. So if is 35 is minor risk factor, the answer is yes, because it is equal to or more than 35. From 35 to 40 is minor. And from 41 onward, if it is written in the recall 41, this is for sure a major risk factor. Then what you have to do, this is what they want to know, that you have to do the umbilical artery Doppler from 26 to 28 weeks. But at least you should know that this is a minor or this is major.
Like cigarette, 11 or 10.
Yeah, just imagine.
Yes.
Yeah, 10 up to 10 cigarettes, because the definition of light smoking and heavy
10
smoking. I
minor,
can
11 major.
Yeah, until 10 is minor and from 11 and onward is major. If you don't concentrate on these points, how you will answer the options from the options? What you have to do? You have to go for the umbilical artery Doppler from 26 to 28 weeks. But if she is smoking 10 cigarettes, you have to combine. Your cutoffs are tricky. I want you to concentrate on this cut points, cutoffs. That is why, that's the reason I want you to, and I'm telling you what you read in revision, what you need to read. So do you agree with me, Mustafa, if you read like this appendix and if you read this one, all the management in one place, you don't have to read the whole guideline. You can revise guidelines very fast in 5 minutes. What is the problem in revision in 5 minutes? You can revise this in 5 minutes. Okay, let's go to this. For example, TOG article. Now you will say, okay, green top guideline, they are making life, all the guidelines, they are making our life very simple. They are giving summaries, bold letters, logarithms. So just go through these bold letters and the appendix, important appendixes. That's it. You can revise one guideline in 5 minutes. You can revise the whole module in 4 hours, 4 to 6 hours, depending upon your concentration. If you go very fast like this is about revision. If you know the topic very well, you cannot revise in 5 minutes if you don't know the topic. If you know that this guideline very well, you not only read it, you understood it. How you understood it? You discuss it with your mentors, you discuss it with your study partners, and you did the recalls related to this. This is how you can say that, okay, now I can revise it in 5 minutes. So it is not something, a magic, that you can revise anything in 5 minutes. It will come automatically. Once you are comfortable with one guideline, you can revise it in 5 minutes. There is no problem at all. For example, this TOG article, cardiac disease in pregnancy, there's part 1 and part 2, right? Congenital and acquired. Can you revise it in 5 minutes? Now, TOG article, there's a lot of information. But still, in every TOG article, there are some important points. For example, just concentrate on this. What is the incidence? Now, incidences are important from SBA point of view. All these gestational ages is cut off, incidences, prevalences, figures, how many percentage is important from the SBA point of view. The epidemiology and all these things are coming in SBAs. Now, congenital heart disease. For example, these first 4 lines are important. Okay, let's see. And what is important, for example? Now this table is, this box, these 2 boxes are important. I have seen recalls asking about this. Do you remember, Mustafa? They were asking about very tricky questions. They were asking if the aortic root is 4 centimeter. So is this an indication for cesarean section or not? And there was something else in other recall. They were asking about this cutoff of 4, more than 4.
Yes, I don't remember number, but contraindicated for pregnancy and more than 4 contraindicated for indication for CS, more than 4. But I don't remember. I don't remember this number.
The recall. They were asking about the if you will, you should avoid pregnancy at night. It is written in another point that it's like a contraindication because mortality rate is very high, and there is a figure for the mortality rate that is very high, 20% something mortality rate if the aortic root dilatation is okay. Maybe it is written somewhere that when to avoid pregnancy. She's right. 4.5. So if it is 4.5 or more to avoid pregnancy, and if she become pregnant, we discuss about termination. And I think even with termination, the mortality rate is 7%. But if you will allow to continue, the mortality rate is 20%. Anyway, so it's an indication for cesarean section. If the aortic root is more than 4 centimeter, you should know this. And for example, this one, the predictor for adverse pregnancy related cardiac events. If the mitral area is less than 2 square centimeter, and if the, you should remember these things, and if the aortic valve area is less than, they're asking. Can everyone mute their mic, please? Let me see. Mute your mics, please. Okay, so you should remember this. Mitral valve area, aortic, what is written there? Concentrate, what is written there? Less than 2, less than 1.5. You know, ejection fraction, less than 40. This is a predictor for adverse pregnancy, so it's a high risk factor. You know, and it's the definition of severe mitral stenosis. So they might create a scenario out of these figures. So you should concentrate on these figures, the cutoffs. For example, they're asking a lot about Marfan syndrome. So I'm telling you what to read from this TOG article. What are the things that you need to revise? You need to revise this table. You need to revise Marfan syndrome because they're asking a lot about Marfan syndrome and maybe pulmonary hypertension. For example, you should know what is Marfan syndrome. Is it autosomal dominant or autosomal recessive? Yeah, it's a inherited.
Autosomal dominant.
Yeah. Go back to your part 1. Read all the, I think Mustafa has given a table in one of his recalls, and I think you posted. So go back to your part 1 knowledge. You should know all your autosomal dominant, autosomal recessive, or X-linked recessive because they're asking about it. They are creating scenario, and you are supposed to know. They will not say this is autosomal dominant or this is X-linked recessive. They will just give you a disease like Marfan syndrome. They will just give you like Duchenne muscular dystrophy, and you should know that this is X-linked recessive or autosomal recessive. You know, and then they are asking about how much the babies will be affected, kids will be affected. So they want you to know your part 1 knowledge also. So Marfan syndrome, the risk of aortic thoracic aortic aneurysm leading to aortic dissection, rupture, and increase in pregnancy. This is the result of the stress. You see this one with an aortic root smaller than 4 centimeter, the maternal mortality is 1%. And this, now this figure is important also. And this can increase to 25% as the aortic root diameter expands beyond 4 centimeter. Do you remember it is written more than 4 centimeter? In this situation, pregnancy should be, what is written there? Beyond 4 centimeter. Okay, pregnancy, and this is copy and paste. In this situation, pregnancy should be postponed until aortic arch replacement is done. In the event of an unplanned pregnancy, option is termination of pregnancy should be discussed. Now, aortic root diameter should be monitored throughout pregnancy with serial echoes, and if the dilatation occurs, then give beta blocker is advised, hypertension treat aggressively. Just I'm giving you an example, I'm not teaching you. I'm just giving you an example. Sometimes they are asking about pulmonary hypertension. That's why this is important. So how many slides? 4 slides. This is all information about pulmonary hypertension. So how many slides? One. This is not a big slide, also introduction. Actually 3 slides. 1, 2, and 3 from one of the TOG article. So this is how you can revise. Now tell me, because I want to discuss recalls from now. And I want to ask you if you have any question in your mind about how to revise. Can you revise in 2 weeks now or not? For the people who are going for January exam.
Yes.
By following this, it depends upon your background knowledge. It depends upon your background knowledge. Again, I'm saying that it depends upon your background knowledge. If someone has summarized a TOG article for you and will give you ready-made, then this is perfect. So, but you can also do it by yourself by doing more and more recalls, and then you will have an idea that from this TOG article, okay, this is coming in exam mostly. People are asking me about the TOG articles. This is a common question. Should we do like last 3 or last 5 years? And my students know this answer very well. Are there any of my students there? Athil? Dr. Daraksha? Anyone? Okay.
Yes, hi, I am here.
Yeah, Dr. Daraksha. So how many
Yes.
TOG articles you should read? You should revise. How many years?
How many?
How many years back? How many years back you should go back to read the TOG articles?
Sometimes I have noted some questions which are very, not very recent.
Yeah, this
Even
is exact.
2008, like I noted, and some. But I have one question also.
Yeah.
Like if there is any scenario which involves NICE as well as GTG as well as TOG, but there is sometimes there is little variation in there. So which one we will follow? What I know, we should follow NICE first and then GTG. Or what do you think?
I don't think so. There is a little thing which I want to add here. So both are reliable, right? Because RCOG is recommending NICE in their own website. So it means it's a reliable and they are recommending it. Strategy is recommended by RCOG. Faculty of Sexual and Reproductive Health is recommended by RCOG. So all these guidelines which are recommended by, they are all reliable guidelines. So you go to the one which is the most recent.
No,
The most
my
recent.
question is one single thing which is variable. Like TOG has sometimes given different response, but we should follow NICE first, yeah? Like one day we discuss even one question.
This is what I'm telling you. You follow the one, even if it is green top, you can follow it. If it is more recent, you follow the recent guideline. And while doing, I will ask Mustafa what is his experience. But my experience while doing recalls and while I'm answering the questions.
I am a student, not experience. I am only in recalls.
No, I'm just asking you.
No,
That
I want to tell you about talk Dr. Hasnia mentioned here, talk 2014, very important. Yes, very important.
I didn't see. Okay, yeah. So
First
what
one.
are the
Second one,
top?
last 3 year. Last 3 year.
I have a different point of view, Mustafa. Let me tell you my point of view. You know,
Okay.
so sometimes, so whatever, for example, you have a TOG article, for example, about male infertility, right? And you have a recent TOG article. So you have an updated one. So you don't need to go to the 10 years back article of male infertility, for example. But for example, there is a cervical cancer talk 10 years back. There is one talk 8 years back, 10 years back, and then they never repeat it. This topic was never being discussed in talk after that. So I can go back to 10 years. It means there is no problem. But if there is a contradiction between this talk and the new guideline, I will take the new guideline. But I can read that one, which is even 8 years, 5 years, or 10 years back. But I go maximum by 10 years, not more than this, because it will be too much outdated more than 10 years. But I can go back to 10 years if I don't see that this topic is updated. You just need to cover your syllabus. You have a guideline and you are looking for a talk article. So I realize that in order to pass the exam, one guideline, even if it seems complete, is not complete. And you cannot pass exam by only reading this guideline. You have to take help from at least 2 or maybe 3 sources in order to cover that topic completely and in order to answer the EMQs. So if you think that one guideline is enough, it seems or it looks to be complete, but it is not. So you need to read. You might not find the TOG article recent. You might find it 5 years back, 6 years back, and I don't mind to go 6 years or 7 years back. For me, the repeated questions from recalls in my exam was 10%. Sometimes it's less than 10%. Sometimes the only the topic is repeated, but they will change the scenario. So answer is not the same. The important, so I never consider and I never thought about it, what is the percentage that is being repeated exactly? Because I am not thinking about it. What I'm thinking is that what are the important topics? I should know this topic very well because they can bring this topic again with a different scenario, with a different answer, and I cannot just copy and paste my answers. So you should know about the topic more than concentrating on important points, more than concentrating on how many recalls are being, you are doing recalls. Now you should know why you are doing recalls. You are doing recalls not to learn that this might come in the exam. No, you are doing recalls with the idea of how to manage and how to do the recalls in exam and how to pass and how to attempt an EMQ, to understand what is in the mind of the examiner. You are, from this point of view, you have to do the recalls, not from the point of view that you will just copy and paste and you will just uh, so you need to understand, because sometimes they change the scenario. You cannot copy and paste the answer. It might be a wrong answer. Dr. Mustafa, before I'll move to the recall discussion. Solve questions and okay. So anything you want to add?
No.
As we supposed to solve questions in last 15 days or just theory part? Now you recall discussion is a continuous discussion. You do it all over. From 6 months start recall discussion. Don't leave it to the end. No? That's why I'm doing recall discussion with my candidates, sometimes free, sometimes paid courses, all the time, all the year I'm doing it. For the July exam, I announce my recall session. So do it every week, once per week, do recall discussion. Don't leave it at the end. Because you should understand my point. Why you are doing recall. You are doing recall in order to understand from where you will read for the exam. You will know after doing recalls from where to read, what is in the mind of, what is important in the mind of examination point of view. That's why you are doing recalls, not because you will just copy and paste from these recalls and the 10% might come. No, this is not your point of view. So don't spend only 1 month. You spend many months for doing recalls, as much as possible. 3 months, 4 months, 6 months. There is no limit. Any more questions? Because I want to solve some recalls with you.
Ma'am, you mentioned about the cutoff that a consultant has to be there for a placenta previa section. Which guideline? Which guideline is it present?
I think it was, I showed you good practice. Which good practice? Let me show you.
And even the BMI, is that a cutoff for the consultant to be
Yeah,
there?
there is
BMI
a
more than
BMI
40.
cutoff for sure. Have you done cesarean section for a BMI more than 40? It's very difficult. This is the one. Let me show you from where I bring it. This is your question, right? Good practice.
Good practice. Okay. Thank you, ma'am. Okay.
Okay.
Thank you.
Let's come to the recall discussion. I'll close my screen here. Dr. Mustafa, I want to ask your permission because I'm going to show the recalls, the one you have collected. Although it's free posted in your group, but I want to show from this one. Mustafa?
Okay. Yes, yes.
Okay, thank you very much.
Okay.
Let's share this one. This one in July, right? 2018. Now this is the question. Now in order to solve EMQ, you should know how to read the EMQ. Can anyone read for me this EMQ? How you can read it? Now it might be 3 lines and it might be half-page question. So you should know how to read so you read the main stem and you just look at the options. You will not read the options, you will just look at the options, have a look only, and then come to the main question. Now this is the main question. How to read this main question?
Dr. Samira, can I read?
Yes, please.
Patient with chronic migraine, postpartum headache with papilledema, diplopia, excruciating pain with controlled hypertension, query 140 90 mm Hg.
Okay, so if it is options are preeclampsia, intracranial hemorrhage, subarachnoid hemorrhage, central venous CVT, what should be the answer and why?
They say the BP is controlled, so no possibility of hemorrhage, like subarachnoid hemorrhage. So she already has history of migraine. Then we might think of migraine again.
Migraine is a
Or
distractor.
okay, excruciating pain. CVT.
What is the buzz point?
She has papilledema.
What is it, doctor?
Papilledema.
Postpartum.
Yes, 2 buzz points actually, not even 1.
Yeah. Postpartum
Papilledema and diplopia.
Yes, so these are the 2 buzz points. Because not in any other, not in migraine and not in preeclampsia, the intracranial hemorrhage, papilledema don't happen, and diplopia and papilledema happens only in CVT among these options. And why intracranial? What are the symptoms, signs and symptoms of subarachnoid hemorrhage or intracranial hemorrhage, which happens with preeclampsia? First of all, it happens, there is a cutoff of diastolic, right? What is the cutoff that you can say, no, systolic, sorry.
More than 160.
Hemorrhage is related to systolic hypertension.
Yes.
And what is the cutoff?
160 or above.
160.
Yeah. So we should know that this is not, 140 is not a risk factor for intracranial hemorrhage.
Subarachnoid hemorrhage, yes.
So, and migraine is a distractor. They are giving distractors also to distract you, to know that you exactly know your knowledge or not, and you are not getting distracted. And
so, Dr. Samira, they are very good distractors.
They just want to know that, are you sure? You know your knowledge very well and you are confident.
Okay, so it's a multiple function question. They want to assess our self-confidence, our self-belief, our self-knowledge.
Everything. This is a skill, by the way. Confidence is a skill.
That's right. That's right.
And you can, if you know your knowledge very well, you can answer your questions confidently. There are some calculated guess also, which most of the time is right. Even if you are guessing and you have some idea about this, mostly it is right. But the guesses which are, if you don't know anything in EMQs, it is very difficult. Unlike MCQ. In MCQ, if you don't know anything about this topic, you never ever even heard the word of CVT, and you are attempting the question, you can even pass this MCQ. That's why they remove the MCQ. But in EMQ, it is not possible. Very rare chance that you don't know about the topic and you can answer it right. Okay. So it is CVT.
Yeah.
And I want to show you my evidence from where I bring this. So you know the headache talk. So it's just a screenshot from this one, and it is written here. Can you see my arrow?
Yes, these
More
include
often other clinical
papilledema.
manifestations present at onset. And headache is, how is the headache? Acute or subacute? Localized, continuous, moderate to severe. And what are the other manifestations?
Papilledema, focal deficits,
It is written
altered
over here. Sometimes they
consciousness,
might give you secrets.
seizures.
That patient
Sometimes in the question, yes, they give the level of consciousness is changed. Lost the consciousness. Sometimes they give in the question.
Any one of them. You should know all the manifestations and cranial nerve signs, in particular diplopia. It is written very clearly. caused by sixth nerve palsy. And even psychosis have been reported also. All these things, they can give you any of them. It's not important that next time they will give you the same manifestations. They might give you other manifestations, like doctor said. They give altered consciousness or seizures, for example, or psychosis, whatever. So exactly these wordings are written in the TOG article. This headache TOG article is very important, and they are asking a lot of questions from this.
Yes.
Okay,
Yes.
let's go back. So the answer is, let's go to, who want to read this one?
I can read, Dr. Samira.
Yeah, please. Go on.
Yes. Patient was in the first stage of labor with epidural anesthesia. She needs top-up. As she now under intermittent monitoring, what is their recommendation regarding fetal monitoring after top-up of epidural?
Now, 1 second, stop here before you answer. I want you to read fast and read the important points only. Like
Okay.
all of us know the question. It is in front of us. All of us can read. Now just read like you are reading in examination.
Patient was in the first stage of labor with the epidural anesthesia, and then she had the intermittent monitoring. Now, after top-up, what we should do? So she needs the continuous. Yeah. Yes.
No, I know that you know, but just I want to.
That's right.
I want you to imagine that you are in real exam and
In
how
the
you should
real
read
exam, with the top-up of serotonin, endorphins, and adrenaline release.
And
That's
you
right.
are very relaxed now. I can understand this.
Yes.
So there you will read fast. I'm sure.
Okay.
So
Thank
what
you,
is the
doctor.
answer?
So
Should
she
you
needs
do
the continuous fetal heart monitoring after the top-up of the epidural.
And for how many minutes?
Half an hour, as far as I remember.
Yes, exactly.
Yes,
I
half
want
an
to show
hour.
you where it is written. I mean, everything is written either in TOG article or in guideline. Most of the things are written over there. There is very, sometimes they are bringing. Now, for example, perform continuous CTG for at least 30 minutes during establishment of regional analgesia and after administration of each further bolus of 10 ml. So if they will bring you a question in which they will say that she received a bolus of 5 ml.
So no need, again, intermittent, because it's not on that level of 10 ml or more.
Yeah, so I'm just telling you, do not just concentrate on question answer. Go back to the guideline. Read from there. What else is written there? They might bring you another thing. They might say she received 10, she received 6 ml, she received 7 ml. For example, you should know the cutoff, what is written here. And how much is the monitoring of blood pressure? I remember they asked once about it. How you will monitor after epidural?
After epidural, I think the blood pressure, I haven't been in that club, but from my knowledge,
every
it
5
should
minutes
be
for
for
15
the
minutes.
first of every 5 minutes for the. Oh, okay. Please go ahead. Yes, please. We are listening. You go ahead. I'm not sure.
Yes. So you see what is written in the same guideline, a page before this one is this information. And because and it will be written there. So just concentrate on the cutoffs. During establishment of regional analgesia or after boluses, so they might create a scenario in which one top of bolus is given, and they will ask you next time not about CTG, they might ask you about blood pressure monitoring.
So how long blood pressure should be checked every 5 minutes for the first 1 hour?
For 15 minutes, just 15 minutes.
Oh, that's 15 minutes. Yeah, I read now. I saw your arrow. I follow it. Yes, doctor. I saw it.
Yeah, this
Yes,
one.
yes, I
5
saw it.
minutes for
Yes,
15
yes.
minutes.
I saw it. Yeah, yeah.
Okay. And when to recall the anesthetic? I mean, for me, this is important. So my anesthetic will be very upset. He came and he will give top up, and after 10 minutes, I will call him that it's not working. He has right to be upset or not?
Who, the patient or the
No,
anesthetist?
the anesthetic.
Anesthetist will be shouting us, doctor, honestly.
Yes.
He will
Even
shout
if you
us.
call him after 30 minutes, he will be shouting still. But what is written in the guideline that he will be pain-free 30 minutes after each admission. So you have to, wait for some time before you recall the anesthetic. This is a small thing is even written in the guideline. But practically, from practical point of view, is important. I never saw it coming in the recall, but it might come. Who knows? Let's go back.
Yeah, that's right.
Okay.
Yeah.
Now you know the answer already because you went back and you saw from the topic. So there is no doubt. For example, yeah, the same thing is written here also. Okay, oh, sorry. Now, this one, who will read for me? This one,
Pages.
number 3.
Question number 3. Shall I
Yes.
read it, or if the
Yes,
other
please.
friends? Okay. What's the best indicator of ovarian cancer? Oh, I lost it. That maximum. Okay. What's the best indicator of ovarian cancer which will help in managing and triggering the patient? So,
Triaging.
what is the best indicator
How to triage the
of the triggering the patient conduct? The best indicator.
So this is for premenopausal women. The questions are we are collecting. People like us are collecting, and it's not complete sometimes. But just we have, and we are doing it because we want to have an idea, right? So in premenopausal women, what is the indicator of how to triage the patient?
Oh, triaging the patient in premenopausal, right?
Let me give you
So,
options. Should you use CA-125? Should you use what you call it, the ultrasound markers or the aorta markers, or should you do the RMI?
so RMI is very good indicator.
But that
But
is in
no,
postmenopausal. That is in
postmenopausal.
postmenopausal.
That is
In
true. That's true.
perimenopausal, aorta is the best, I think.
Yeah.
And overall, also it is IOTA LR2 rules.
What is in premenopausal? What was your answer, please?
Aorta, that is yani ke
Aorta. Okay.
about
Okay.
ultrasound, yani ke
Sure.
benign and malignant features you should know.
Yeah, the finding of
And
ultrasound also. Okay.
B
yeah.
rules, M rules. You remember
Yeah.
aorta?
Yes. B rules and M rules.
Now look at the sensitivity and specificity. Sensitivity is 95% and specificity is 91%. It's very nice, and likelihood ratio and negative likelihood ratio is 0.06. It's, I mean, very nice. So B rules and M rules for premenopausal. But for CA-125, what is the problem in premenopausal women? Why it's not reliable? And RMI is depending on CA-125, right? But why in premenopausal it's not reliable?
Can be elevated in other conditions like endometriosis.
In premenopausal women, there can be fibroids,
Yes.
there can be endometriosis, and there are other factors also. Sometimes I'm forgetting, there are 4 or 5 factors in which it is raised in yes, PID, yeah, that's true. There are things that especially for premenopausal women they have, and it can increase. It can be increased. That's why we don't go for CA-125 in premenopausal. There is a logic behind everything.
Even CA-125 is a marker of the epithelial cancer, epithelial type.
There are serum markers specifically for it's a marker for serous epithelial tumor.
Premenopausal is epithelial melanoma more.
That is true. Do you know the marker of mucinous epithelial tumor?
CA-19-9.
19-9. 19.9. So, okay. So there are tumor markers for granulosa cell tumors and choriocarcinomas. 19.9. Yes, this is how you pronounce it. So let's go back. Now this one, who will read for me? Now this is very nice. I want someone who knows about this antiphospholipid.
May I read, madam?
Yeah, please go on.
A patient presented with the history of previous 3 miscarriages of first trimesters. On investigation, value of antiphospholipid antibody was 20 gram per liter, less than 40 gram per liter. Thrombophilia screening factor 5 laden was within normal limits. When will she get pregnant? What is the best treatment option for her?
Yeah. So the options are, should you reassure her? Should you start Clexane? Or should you start aspirin? I mean, what should be done?
Reassure.
She has a history of 3 miscarriages, first trimester, and antiphospholipid is 20, and thrombophilia was also normal, and factor
So by
5 laden.
the definition, they want to know that if you know the definition of antiphospholipid or not. So the options were like, should you give her Clexane? Should you give her aspirin? Should you reassure her only? Among these options, just choose.
Aspirin.
We'll give
Reassure.
her aspirin. Now, practically speaking, if she will come to our clinic, we will give her aspirin. I know, all of us, most of us, not all. But what is written in the guideline?
We'll reassure her.
Just
We
reassure.
reassure because
Yes, why?
It is screen is negative.
Now, by definition, is this a patient of antiphospholipid syndrome?
No.
no.
Yeah. So what is the definition? Again, come back to your knowledge. Definition of
IgM levels are more
antiphospholipid
than
form
40.
Definition
particles.
is
Interval of 2 weeks.
More
12
than
weeks.
0.1 percentile. Or
two
more than 99%.
or more than
On 2
3
occasions, 12
abortions
weeks apart.
first trimester, and more than 10 weeks, less than 10 weeks, I think morphologically normal miscarriage of the
From this
fetus.
category,
And
3 or more unexplained spontaneous miscarriages, what they mean before 10 weeks.
yeah,
You see, I think
yeah.
this is what she is, and one of the laboratory factor. Look at the laboratory factor.
That was also less there, no? That was 20 there.
It was
And
20. So you should know again cutoff. Why I am
yes,
stressing you about cutoffs? Again, you should know the cutoff. It should be medium or high titer. And what is the meaning? You see in the recall, they did not say medium or high or low. They just give you the level 20. It means they want you to know that what is significant by definition. So the significant, which is medium to high, is more than 40 is significant. And you
yeah.
should know that at least it should be 1 clinical and 1 laboratory. And
Yes.
you should know also that it should be repeated.
If there is less than 12 weeks or 5.
It should be repeated at less than 12 weeks and not more than 5 years.
Yeah.
Between the positive and the clinical, they should be, actually it should be repeated twice, like within 12 weeks. So these two should be repeated. This investigation should be repeated as it is written, 2 or more occasion, at least 12 weeks. At least 12 weeks, sorry, at least 12 weeks apart.
Yeah.
At least 12 weeks apart. So, and you should know the titer. And you should know that at least 1 clinical, which is this one.
Clinical, yeah.
Or this one. or n plus 1 laboratory criterion.
One laboratory.
And it is written in the TOG article. So whenever you see a recall, you go back, because they might give another scenario. So you should know everything about antiphospholipid. In this TOG article, if you read this table only, you can answer most of the questions.
So,
For the people who want to know that how to revise and what to revise. Okay. Because in TOG articles, the flow charts, the tables, logarithms, if you have no time to revise, and if first of all, you should highlight the important points while you are doing first reading, like 6 months before, 1 year back. If you have not even highlighted, just read the boxes, logarithms, flow charts. Okay. Who will read this one? This is about the immunosuppressant medications. And they are asking not only one time, they are asking many questions related to this immunosuppressant. Dr. Ghazala, you like to read it?
yes, please. A 27 years old lady had a renal transplantation 2 years ago. Now she is pregnant on some immunosuppressant. Which immunosuppressant will not cause gestational diabetes? Yani ke usually the immunosuppressant cause gestational diabetes, but which one will not cause?
Yes. For example, they might give you like azathioprine, tacrolimus, corticosteroids. What else?
Tacrolimus.
Yeah, tacrolimus. They
Cyclosporin.
might give these options of immunosuppressants, right? So which one will not cause gestational diabetes?
Azathioprine.
Mycophenolate.
Azathioprine.
I think azathioprine. Remaining, if there is a choice of prednisolone, it will
Prednisolone
cause.
is prone to gestational.
It will cause. Yes, it will cause.
Cyclosporin, for example.
Cyclosporin causes,
That will also
tacrolimus
cause.
causes,
That will also
prednisolone
cause.
also causes.
Now,
Azathioprine,
who
yes.
is answering this question? I want to know your source. Although azathioprine, what you answered is right, and I don't disagree, but I just want to know the source. Whenever you are reading any recall, the rule of thumb, you go back to the evidence. Now tell me the evidence.
Actually, we read it from the recall. I don't remember that we
Whenever
try
you
to
are reading
find out the
discussing
cause.
a recall with your study partner, you should always open the evidence. Otherwise, there is not much benefit of doing it. So, Dr. Mustafa, are you still with me? Or you are bored and left?
Yes.
Oh, wow. You are still there? So please, can you
Yes, I am.
tell all of our students that from where to know the answer of this? What is the evidence?
In TOG, I think written this one. In transplant
Renal transplant talk?
organs, yes, I think.
Is it written? Because I didn't, sometimes I'm asking you not
Yes.
because that I'm asking you as a teacher, but because I don't know. That's why. You see?
Yes,
This
in
is
TOG. Yes.
all the information is there, okay?
Yes.
But this information about gestational diabetes is not there. Maybe, as you said, this one I took from the IBD, but maybe it is from the renal transplant talk. I don't know. But about gestational diabetes, although I have all information about it, for example, where is azathioprine? Azathioprine is FDA category D. There is possible teratogenesis also in pregnancy. You can give it. Breastfeeding, you can give it. And here, no increased risk of preterm, low birth weight, neonatal adverse or congenital, nothing for the baby. And it is preferable as fetus cannot convert to convert it, so there is no problem for the baby, for the baby at all. But it is not written in this table that it causes gestational or it will not cause gestational diabetes. Or maybe, for example, just talk about this one. Yeah, here, for example, for steroids, it is written it can cause neonatal adrenal suppression at higher doses, prednisolone preferred as rapidly metabolized, give a stress dose at delivery. Okay, it can cause gestational diabetes. It is written very, but maybe I assume that because it is not written here, that's why it's not causing, right? Because for steroids, it is written that it will cause gestational diabetes. Like for tacrolimus here, yeah, that's true. So for tacrolimus, we can say limit use of fulminant colitis and rescue therapy in steroid refractory. There is a possible association with low birth rate and preterm birth. It's not written here that it can cause but it has some steroid refractory ulcerative colitis. It has something more or less like steroid. And infliximab, also it's not written. Mycophenolate. Only what is written about gestational diabetes is about steroids, that it can cause, and we know already this information. So, but as you said that it is written in renal transplant TOG article, I believe. Oh no. But anyway, it is azathioprine. So this one, who will read for me this one? Number 6. This is very interesting, Mustafa, and the answer which you have given, I want to discuss on it also. So who will read for me?
I will continue, ma'am. No problem.
Okay, Razana, do it.
50 years old lady using levonorgestrel IUS for contraception, but since 1 year she is amenorrheic. When could she stop contraception? Her age is 50 years and she is using IUS for contraception, but since 1 year she is amenorrheic, so she is postmenopausal since 1 year. When could she stop contraception?
1 more year.
To
check her SSH.
1 more year.
What is written in the
Yes.
Faculty of Sexual and Reproductive Health Guideline? Although by definition, she is menopause, right? Because she's
To confirm
50 years
menopause
for,
first.
she has
Yes.
amenorrhea
Yes.
for
1 year passed.
yeah, she has
1
for
more
1
year.
year. By definition, she is menopause, and we don't need to do FSH testing because she is already
Yes.
menopause by definition. Okay.
Yeah.
Now the question is not this. They are asking when to remove the Mirena, when she will not need it, which is written in the Faculty of Sexual and Reproductive Health Guideline. Should we remove it now?
1 more year.
1
more
No,
year.
she
1 more
can
year.
continue 1 more year.
Yeah, but Mustafa, although it is half of the question, I agree, half of the answer. But there is no indication in the guideline that we should do FSH level. It is written in the guideline that we should remove Mirena, or she will not need it after 2 years, after 50 years.
Even
You
without
know,
FSH?
in every questions I put evidence, but sometimes repeated questions. Only I put answer.
That's right, yeah.
Okay.
And I see 5, 6 questions without maybe repeated questions.
That's right.
Yeah, it's a repeated question. It came like 2 or 3 times. For example, what is it in here? Women who had their Mirena, and it should be like 52 milligram, inserted for contraception or heavy menstrual bleeding at the age of 45 or over, can use device for 7 years until or if amenorrheic until the menopause. Now 45 years, if you calculate 45 years onwards, 7 years, it means how many years?
Yeah. 52. It will become 52.
It is 52. It is not written directly 52, but you're using your, I mean, your logic, right? That it is 52 years. And if she is amenorrheic before this, then she can use it until the menopause. Now, here in contraception for women aged over 40 years, there is something written here. If needed, women over 50 using progestogen only contraception, which includes Mirena also, right? Including Dempa and everything, I think, can have FSH measurements undertaken to check menopausal status. Now here they are writing that for 2 years we can remove it after 2 years more, which means 7 years means 52 years. But here in this guideline they are saying that if needed over 50 years, FSH can be checked. So the answer to this
I
question,
think that's because when you are taking progesterone, you might not be having cycles regularly. So there is no other way to find out.
yeah. If she is more than 50, and most of the time in Mirena there are no, there is amenorrhea, right?
That's right. Yeah, it creates amenorrhea. Yeah.
Yeah. Shall I show the? Okay. During the, this is the evidence which Dr. Mustafa is sending. Let us see now. During the perimenopause, FSH levels can fluctuate, neither a single nor the presence of menopausal status. For women over 50 who do not use hormonal methods, conception can be stopped after 1 year of amenorrhea, as fertility is unlikely to return. In women under 50, contraception should be continued for 2 years, as the return of I have seen this one. Hormonal contraception can affect bleeding patterns, making it difficult for women over 50 using oral progesterone, subdermal implants, and IUS. FSH recommends that contraception should be continued for 1 year after recording 2 FSH levels at okay,
Above 30. Yeah.
Mustafa, this is from where? From where you copy and paste?
From guideline related to contraception. Which one?
Okay, from the Faculty of Sexual and Reproductive Health guideline, right? Okay, I agree. So it means the options are right. This is the transparent in pregnancy. This is from where you took the other information, right?
Previous questions.
Yeah, the risk of gestational diabetes, GDM, in renal transplant is equal to tacrolimus, cyclosporin, and prednisolone, diabetogenic effect. Okay. So this is from the renal solid organ transplant 2016.
Yeah.
You see, this is how you read the EMQ. You should go back to your evidence. Don't believe in any one of us. Ask us what is the evidence. Okay. Now we are very much sure from wherever they will give the question, we have our concept. And we know the evidence from where it came. So we can argue with someone that, no, I know this is from SHOP 2016, solid organ transplant. And I know this is written in Faculty of Sexual and Reproductive Health, blah, blah, blah. Okay. Ghazala?
Yes, please, doctor. Yes. Next is 82 years old lady presented with pigmented vulval lesion. She is complaining of itching, and on examination, satellite lesions were found. What is the diagnosis? Okay, she is 82 years, and she has vulval lesion and itching. and satellite lesions. The key point is here satellite lesions
Candida,
and
is it
itching.
vulval cancer?
So candidiasis come in my mind.
And or it is
No,
malignant
it's melanoma,
or
malignant
squamous cell
melanoma,
cancer? Okay.
But
pigmented and
satellite
satellite
lesions,
lesions.
itching.
Now
Satellite
there is a
lesions with
Uh,
pigmentation
Candida
go in
and
favor of
melanoma.
melanoma.
okay.
But why I will choose melanoma? Why I will not choose Candida? Both of them have
I am
satellite.
Age of
yes.
the patient.
In my
Age,
mind, candidiasis came.
no, her age is 82 years, plus she has pigmented valvular lesions, plus satellite lesions that go in favor of melanoma.
Satellite lesions plus spotting young age go to candidiasis and old age go to vulval malignancy. Even Mustafa is quiet, but he's talking, showing a lot of evidence, mashallah. Okay, so that is true. Age is the buzzword. The buzz, what is the buzz? Is the age. And by the way,
Age and
what is satellite lesion?
uh, like satellite, yani ke if you see the candidiasis, it is uh, all the portion is like satellite. Uh,
I mean, what is the definition of anyone?
scatter type. It is.
Yeah. It's something
Yes.
scattered. Now, scattered
Yes.
from
So
where?
you're asking about the appearance of satellite lesion is definition or marker for what?
Definition.
What is
I
your
want to know
question,
the meaning of
Dr.
satellite lesion in English, maybe.
Satellite, it's some like when there are something around, like a
Around,
circular surrounding the
Satellite.
central
just
around,
around.
like
Yes, you are very
satellite in
creative.
our TV. Yeah, like a satellite in our TV, like connecting to the
Connecting to
signals. Yeah.
connecting to the principal lesion. So these are small lesions near the edges of the principal
That's
lesion.
right.
Is a
Satellite.
satellite
Yes,
by
yes,
definition.
that's a
Just if
satellite.
you Google it and you
Yeah.
will find this definition. Anyway,
Yes, satellite.
sometimes you just need to Google things and make
Yes.
your life easy.
Always
that's why
we need to
use everything possible, whatever is easy for you. Don't worry. Okay. So yes,
melanoma yeah, satellite. I remember in lots of recars that was a good like the clinch mark for melanoma, satellite lesions.
that is true. Which can happen, and they will always give you something answer option very near to the first one.
Like what?
But for example, this one also it's near. Like Dr. Ghazala, she chose candidiasis because it can happen also. And you will see in the
Yeah.
recalls many times they are giving very near options, which you to confuse you actually. Just
Okay.
come to this one. Yeah,
Usually two
So
answers, doctor, become very close.
very
Usually
close.
two answers
And this is
become
the
very
key
close. Yeah.
point. If
but
you
here the key point is pigmented lesion. Here
yes,
the key
this is
point is
another key point.
pigmented lesion.
Yeah, you are
Pigmented lesion.
Pigmented with
Where
age
is that?
and age.
Pigmented lesion. Where is that? Oh, yes, in the first line.
Yeah.
That's right. That is
So
a
key
very
point is
important.
this.
That's right.
There is one more thing. Do you know the color of candidiasis, the satellite lesions in the skin under the breast and in axilla? And in the flexor creases of medial side of thigh? What is the color?
Reddish.
Brown.
Reddish and this.
Brownish, brown.
It is reddish brownish. It is pigmented.
Yeah.
Yeah.
Sometimes even the black it becomes.
That's right. Yeah, very dark.
Because of
Brown
the
on the
scratching, because of the repeated scratching, it can be plaque even. So
Yeah.
it can be pigmented, but here I think is the age.
Yeah.
Okay. Read this one.
Next
I
is.
will read. Okay, you read.
No problem. A couple presented with the primary
No, you read.
subfertility. A couple presented with primary subfertility, and woman was normal. Her day 21 progesterone was 32. Male showed oligospermia count, which is 1 million per ml, and second repeated after 3 months, 5.1 million per ml, normal testicular volume.
So what should be done?
Testicular biopsy.
She
Yes.
is primary subfertility. She has this normal progesterone level. So regarding female, it's no problem. Male showed oligospermia count, which is yani ke, less count and less this
Yeah, this is
oligospermia.
the vulval
And
candidase.
even after,
Sorry, I just want to finish this one. Oh yeah,
okay.
may become chronic with the leading edge of inflammation. You see how it looks like with mobile lesion extending out from the into the inner thighs. It can look pigmented. This is what I want to tell you. Okay.
Candidiasis. Oh, okay.
Yeah, yes. It is in the group and shared it in the group.
Sure.
So okay. So is this Ghazala, is this progesterone is normal? Are you sure?
Yes, it day 20. I think
35
up
is
to
normal. 35 is
30.
cutoff.
30, 30
I
is
thought it
normal.
is 30.
What is the
30 is
cutoff?
normal.
Now can you
35 is
30.
normal.
I think it's
tell
30.
me?
I
I
think
heard
30.
that serum progesterone of 12 is normal. Do
Even
you
12.
believe me or not?
Actually,
We
it
thought
depends
above
upon the
30.
unit.
Yes, please. Thank you very much. They might give you. Now, this is another trick the
Yeah.
RCOG is using. They are giving different units, and you should know all the units. Like for MHS, AMH, for serum prolactin, for everything, there are 2 units.
Yeah.
And they are
Yes,
asking
madam.
alternatively units. 12 is normal.
Okay.
This is
Because
a nanogram, which you are telling 12 is in nanogram and 30 is in
exactly.
nanomole. So if it is,
Exactly. So not only you know the figure, you should know the units. So what is normal in nanogram? More than 10 nanogram per ml is normal. And
yeah,
what is normal in nanomoles? More than 30 per liter.
30. Yeah.
Okay. 30. Okay.
So this is
30.
most probably nanomoles per liter, although this is not written here.
Yes.
But regarding this oligospermia, even after repetition, it
Is
is
this normal? 5 million?
no, it is not normal.
What is the normal cutoff?
Normal cutoff serum concentration
Per
is
ml,
15 million. 15
15
million.
per
Per
ml.
15
15
million per
million per
ml.
ml.
Ah,
Yes,
per
per
mil.
ml.
yes.
What
And
is the
what is the
duration of the
definition
fertility?
of
Ejaculation 39, I think.
39 million.
39.
Million per. Yeah.
yes. And what's the definition of severe oligo?
Below 6 million.
Yeah.
Below 5.
I mean,
Below 5.
Below
5
5.
5 actually,
6.
what I read before, but I don't know from where you read 6, but for me less than 5
In
is
one of
5.
the, yeah. Okay, it's 5. I read in the some of the in their records they send, I don't know from which of the guideline, they send a paragraph, not with Dr. Mustafa, it was in another record. They mention if it's below 6, then we need whether like testicular biopsy or karyotyping of the male. But if it's your information, I believe it's so, I will consider
so
5. But that was, yeah.
yeah, it is okay, no problem, because I read it from one of the talk article, this cutoff of 5, but I
Okay.
cannot recall and tell you exactly which was that talk article, but maybe it is in the male infertility talk article. But anyway, whoever is showing you that don't believe it and go back and look for the evidence.
Okay.
Like Dr. Mustafa. So this is the new WHO criteria, right? 2020. It's, I think, more or less the same.
Yes, same.
Yeah,
Only,
vitality the
yeah, same.
same.
Progressive
Morphology.
32,
Yeah.
normal form, same it is. Vitality 58.
Mm. It's the same.
Morphology 4%. Yeah.
Okay. So if I will say morphology 3%, you will consider it abnormal?
Yes. Yes.
Yes,
Yes, of course, because
because it's less than
normal is
4.
4% or
Can you please look at this?
3 to 4, huh?
Yes.
95%
3 normal.
confidence interval.
So
So
less
3
than
is normal.
Oh my
So 3
God.
also is normal. Like,
yeah,
so we
because
should come see.
Reference limit is 4.
yes, it's okay. Average is reference limit is 4, but they might give you from this also. It is from the 95% confidence,
Okay.
which is
So I
fine
don't
also.
know who the examiners who make the questions. If they sit instead of us in the exam, can they pass the exam very easily? The people who made this, I
You know
believe
how they are
not
making
so
the
easy.
exam? They call all the consultants and then they sit and they are creating scenarios from their own experience, you know, but they make sure that the answers are in the guidelines mostly and in the talk articles, but they are making scenarios. These are consultants like us, no problem, but everything is written, you know. I will tell you, we just cannot see it.
But this was new that we have to also memorize confidence interval.
Yeah, because there is a range, there is an average and there is a range of everything, right? Always there is
Yeah.
an average and there is a range. Whatever comes in the range is also normal.
And excuse me, then what is the definition of oligospermia?
Yeah, oligo means, so our cutoff is 15.
15. So if
Our
it is less
cutoff is
than, that is the range is 12 to 16.
our cutoff is 15.
Normal.
And
Yeah.
the range
12
is
to 16.
yeah.
12 to 16.
So if they will give you a scenario that it is, for example, 12 or 13 or 14, you see, then it still comes in
It
the
still
range.
is normal, yeah.
It still comes in the range.
12 to
And
16.
if they give you a semen volume of 1.4, then it still comes in the range.
Yeah, because normally we think 1.4 is abnormal, is low volume.
But it
Normally
comes,
becomes, yeah.
Mustafa, this range of sperm concentration per ml, it was before also the same, or they have changed it?
I think same, yes. I will look.
Because even I'm looking at it now about the range. I did not concentrate on it, to tell you the truth. Okay.
And what is the duration of the infertility?
After you will start the treatment is 2 years.
Yes.
So after 1 year, by definition, is infertility. By definition, is infertility after 1 year.
In this case,
You know,
in this case
according to the
scenario,
guideline in which there is what is it, after 1 year of unprotected sexual vaginal intercourse, if the patient will not get pregnant, then this is infertility. So you can start investigation if everything is okay. You can start treatment, sorry, after 2 years, but you can still do the investigation after 1 year.
in this case scenario, how long?
Yeah, this one, what you will do? Yeah, that is true. If she is 38 years old, you will not wait. Okay, for what should be the answer? Oh, sorry.
I send all and no
How old
reference.
are you? Let's see. So this one is before also is the same. I think. Yeah, this is the same. It's the same. Yeah. Yes, yes. It is the same. But I did not realize it. So if by definition this one is having severe and when as you said that what you will do for the severe is you will do the karyotyping. So what you are looking for in karyotyping? Dr. Ghazala?
Yes, we can. It can be any Klinefelter
Yeah.
syndrome or yeah.
Y chromosome microdeletion.
What you will do for microdeletion? I think it's Y chromosome microdeletion. You will know it by karyotyping?
No, no, no.
No.
It's a genetic
CGH.
testing. You will not know by karyotyping. So, yes, if it is in the option, because this is the only thing in the option which matches with it, then you go for the blood test for karyotyping. Okay. This one, Doctor. Who want to answer before? Ghazala, I think Dr. Ghazala, someone else wanted to. I didn't check the name.
Yes, no problem. Yes, please.
Okay. Who else want to answer this one?
Patient had can I?
Yeah, please.
Patient had laparoscopic hysterectomy. There was deep endometriosis. It was a difficult surgery. Came on third post-operative day with abdominal pain, fever, with reduced urine output. Investigational choice. So,
Yeah, what you are doing? What do you think? What happened?
can be a ureteric injury.
Yeah, most probably. So for ureteric injury, what you do?
IV urogram.
Simple IV urogram,
Yes.
or you will go for CT IV urogram.
Easy.
CT IV urogram.
If available, it should be done. CT.
And I think there is an evidence for this, which I think Dr. Mustafa, he posted it. Now, this is post-operative. We are talking about post-operative, right? A CT scan with contrast may confirm. For the ureter, post-operative, go to CT IVU. So, and this is what usually what we do practically also. If you don't remember what is written, the evidence, I mean, if you are working in a tertiary center or where you are following protocols and all these things, you can have an idea from your practical experience also. Yeah, this one I want to rephrase it, this question. So patient has previous 3 miscarriages, and it is second trimester, for example, miscarriages, right? And she even so maybe she had like cervical cerclage in the last two, and still she had a miscarriage after cervical cerclage. And when you examine the patient, the cervix is flushed with vagina, means very short cervix. So what is the best management plan for her?
Abdominal cerclage.
Okay.
Yeah. Yes.
Should you do it during pregnancy or
Interval.
Laparoscopic.
interval?
During.
Interval.
Interval.
Interval
Laparoscopic?
laparoscopic.
Yeah, there is no doubt about it. And there is an evidence from strategy where vaginal cerclages have failed and the vaginal cervix is absent, like in this patient, or almost non-existent, the patient should be offered a transabdominal cerclage. Although an interval suture has advantages over one performed in pregnant, it is written that interval suture is having advantage. And if you want to do it in pregnancy, do it after 10 to 11 weeks. Or you can do the anti-scan after 11 weeks and then you go and do it. If you want to do it during pregnancy, but interval is more advisable. Now this one. This is also from the guideline. Yes, doctor?
Me,
Yes, Visam.
65-year-old lady presented with postmenopausal bleeding. Transvaginal scan shows thick endometrium more than 5 mm. Next management plan.
It is written in the heavy menstrual bleeding, I think, guideline and
Yes,
also in the TOG article.
She's
Postmenopausal, yes.
postmenopausal bleeding with the endometrial thickness. We can take biopsy.
Yeah. Is it a hysteroscopic directed biopsy or an outpatient blind biopsy?
Outpatient, no need.
There is
Inpatient.
need for hysteroscopy?
People's biopsy. People's.
No people.
Now let's see where is the evidence. Diagnosis of endometrial hyperplasia requires histological examination. Okay. And endometrial surveillance should include, okay. Diagnostic hysteroscopy should be considered to facilitate endometrial sample. So this is endometrial hyperplasia. If you want to rule out endometrial hyperplasia, you can do outpatient endometrial biopsy. And diagnostic hysteroscopy can be considered if outpatient sampling fails or is non-diagnostic. Then you can go for diagnostic hysteroscopy. This is the indication. But initially you can go for the office sampling for postmenopausal ladies especially. But if the lady is premenopausal and she has heavy bleeding, and you did, for example, endometrial ultrasound, transvaginal ultrasound, endometrial thickness is 18 millimeter or more, I mean, extraordinary, and you want to do the endometrial sampling, you will do outpatient or hysteroscopic?
Hysteroscopy, prefer. If you
Yeah,
suspected pathology.
there is a difference between premenopausal and postmenopausal. And postmenopausal is usually you do endometrial sampling office. And premenopausal because it can be a polyp also. Because there are different pathologies in premenopausal women. So it's better to maybe go and treat also at the same time. Okay, so hysteroscopy is preferred in premenopausal and postmenopausal. You can take the biopsy.
Okay.
Yes. So what the options are like polymorphic PEP, polymorphic eruption of pregnancy, pemphigoid gestationis, eczema,
Atopic.
atopic eczema. But there
Atopic
is a
eczema.
buzzword here.
Ectopic eczema.
Extensor surfaces.
Yeah, where is the buzzword?
Extensor surface.
First of
Yes.
all,
Extensor
extensor
surface.
surface, and it's on face.
Yes.
Have you seen many of the lesions
Actually, it is
near
on
the
the
face?
face, neck, and chest. Face, neck, and chest.
Mostly. That's true. Let's see what Mustafa is posting. Dermatosis of pregnancy. Yeah. Face, neck, chest, and extensor. It is written very clearly, actually. In dermatosis of pregnancy, it's a TOG article, I believe. And it's in face, neck, chest, and extensor surfaces of lenses. So And you know, if they are asking many times about a lesion which spares the periumbilical area. If they talk about a lesion which spares periumbilical area, it is PEP, polymorphic eruption of pregnancy.
Yeah.
But unlike PEP, pemphigoid gestationis appears around umbilicus. And it can be to trunk, extremities, palm, and soles, but there is always mucosal sparing. So there are, it is all written there in the table. Okay. Now this one, who will read for me? She is going for abdominal hysterectomy, not vaginal hysterectomy, abdominal hysterectomy, and how to prevent vaginal prolapse.
McCulculoplasty.
Or fixation of uterosacral or sacrospinous fixation or colpus
A.
suspension.
B.
Yes,
Why
because
did you
abdominal.
choose?
Abdominal.
McCulloch is through vaginal.
Yeah. So there is a difference between abdominal hysterectomy and vaginal hysterectomy, right? Let me show you.
Yes.
McCulculoplasty. At the time, what they are writing? Vaginal
Vagina.
hysterectomy. And you can suture the cardinal and uterosacral ligament to the vaginal cuff at the time of hysterectomy, both abdominal and vaginal. And when to do sacrospinous fixation? Vaginal hysterectomy should be considered when the wall descends to the introitus during closure. So don't read half of the sentences. Read the whole sentence. And you should concentrate what is it in. It is it in vaginal hysterectomy. It is it in abdominal and vaginal hysterectomy. This is what I want you to concentrate. Even reading the guideline doesn't mean that you can answer the question. Sometimes I'm showing you the answer and you are giving me wrong answer. Even you are reading it. So read the guideline with your study partner or with your mentor. So that, and how you can have idea, you can even do it by yourself. Just read more and more question and recalls so that you understand from where they are asking, what point they are concentrating. Okay, this one. Dr. Wissam, can you?
Diabetic mother during pregnancy was taking insulin, now shifted back to pregnancy medicine. That was metformin.
Yeah.
Baby was all right after birth, but 2 hours after birth, poor suckling became lethargic. What is the cause of the baby's condition?
Yes.
Uh,
So the options are hypophosphatemia, hypomagnesemia, hypoglycemia, all these things.
Hypoglycemia.
All these things can happen in diabetic women.
Like poor sucking.
Yeah, all these things can happen, but what's the most among these options?
After
Logically,
poor
which is more
suckling, the
possible,
baby became lethargic. So
in which the baby can become lethargic, is hypoglycemia. And this is the most common thing that happens. Okay, that's why we go towards for it. Okay, this is related to the prolapse also. Yeah, Dr. Wissam.
72 years old, sexually active, has short vagina, having a post-hysterectomy, valve prolapse, best surgical option.
Now, what is the buzzword? What you need to concentrate?
short vagina, sexually active.
For both,
Yes.
for both abdominal sacrocolplexy.
Abdominal, yes.
So now
Because
you want to do the
Because she
surgery.
is still sexually active.
The
Yes.
buzzword is sexually active and she already has short vagina.
Yeah.
Contraindicated for sacrospinal fixation, because we have two sacrospinal fixation.
That's why we
and
need to rule out sacrospinous fixation. We will not do it.
Yeah. We have to go for abdominal sacropexy.
Abdominal sacrocolpopexy, not sacrospinous. And now, what you will choose? Laparoscopic or abdominal open?
Laparoscopic.
Abdominal.
What is written in the guideline?
Written abdominal.
It's written abdominal. It's not written laparoscopic. No. If you go to the guideline, I don't know if they.
Abdominal.
You see? Open abdominal sacrocolposcopy. Just read the whole sentence. Open abdominal sacrocolpopexy. And they are giving you laparoscopy because they want to confuse you. Not because they want to confuse you, because they want to make sure that if you have read your guideline very well or not. Okay. This also already we did. This one is simple one. Yeah. Who want to do it? Number 17. We have only 4 remaining because in this session I just want to discuss with you how to, even if you are doing with your study partner, how you your recalls. Okay, this one.
Ectopic pregnancy treated laparoscopically. At that time, there was no problem with hemostasis, but in the postoperative ward, she had hypotension and shock.
Yeah.
So, which artery is bleeding most probably?
Yes.
Inferior epigastric.
So
the secondary
what
port
is the
site.
buzzword?
At that time, there was hemostasis from the stumps at the end of the operation. So, it's not an intra.
So most probably the stumps are fine. I mean the ovarian artery. What can happen in the infundibulopelvic ligament? The ovarian branch of the aorta can be, I mean, can bleed and can lead to death even if you leave it bleeding or if it bleeds. But the stumps were fine. Cervical branch, fine. Uterine artery, cervical branch was fine. Infundibulopelvic was fine. So laparoscopically inferior epigastric artery. I want to ask you, what is the source of bleeding from primary port and what is the source of bleeding from secondary port?
Secondary port is inferior epigastric.
Secondary port is inferior epigastric and primary port? Especially in
Abdominal
Primary port,
right common
aorta,
iliac.
abdominal aorta.
Yes.
And right common iliac.
Yes. So it's abdominal aorta and right common iliac. That's true. But anyway, we are just discussing because mostly this is more common. Have you seen aortic bleeding? I have not seen it. So it's not common. What happened usually is inferior epigastric artery bleeding. So you have to choose the one which is more common. Okay. Although aorta can bleed also. A common right common iliac can bleed also. But the thing is, what is more common? Have you ever seen aorta bleeding in laparoscopy?
No.
I have not seen, but maybe someone has seen it. But I mean, it's very rare. Okay, sorry, this one. And this one, who will read it? This is from the nerve injury talk article, right?
I can read, doctors.
Yeah, doctor.
Yeah. Patient in OR during surgery, her arm abducted more than 90%. And then she developed a palsy. Which part of the brachial plexus was got damaged with the palsy, which is upper plexus of the brachial for the palsy. Yeah,
So lower
because of the
lower
over
trunk
abduction.
plexus,
No,
upper
it is
trunk
lower.
plexus, and what are the nerve roots?
For the lower or for the upper, you mean? Nerve
Which
root
one?
here?
Herbs pulse.
Upper trunk C6.
For S palsy is the upper root, which is the C5 and C6.
You are absolutely right. This is upper trunk. So if you don't know the detail, for me, for people like me, they will only read C5, C6, that's it. But in order to pass the exam, you need to know it's upper trunk or lower trunk. Because it will come in the exam. From the TOG-induced TOG article. It is written upper trunk of brachial plexus. It's a stretch injury.
Lower trunk of brachial is Klumpke, yes, Klumpke's palsy, yeah, which is yes, Klumpke's, yes, C5 and C8 or T1.
Now this
yes,
one is
yes,
C5 and C6.
T1.
No,
It's
that
like
is upper.
Baker's
I was
tip.
talking about the lower Klumpke's.
C8 and T1.
C8 T1.
C8 T1, yes,
C8
C8 T1.
Claw hand, which can cause claw hand. Klumpke's. But and if you are using these two terms, herbs and Klumpke's, then you should know the origin. And you better to know how it looks like. And what is the problem? Motor abduction. In herbs, there is motor function which is affected is the abduction of shoulder and flexion of elbow and supination. So it will be like a waiter's tip. Okay. Oh, sorry. Yeah, now this one.
I can read, doctor. It's okay?
Yeah, please go on.
38-year-old conceive on what is IV? Means IVF? Yeah, past history of past history of right self-injectomy presented with mild vaginal bleeding, vital sign is stable, and ultrasound showed GS size 25 millimeter, but no fetal pole. What's your diagnosis? Is the miscarriage? Because
what is our cutoff for the gestational age for the missed?
Cutoff is 25 millimeter and above. Yes, of the gestational sac, because it's rich.
That there is no fetal pole. So there is a gestational sac. So you should know the definitions.
Yes, yes. No, gestational sac, if to reach to 25 millimeter or above, definitely we should see fetal pole. If we cannot see, it means it's miscarriage.
Yeah. So if is it a non-viable pregnancy?
It's non-viable. It's non-viable. Why it said it non-viability? There is no fetal pole, and the limit of the GS is above 25. It should be non-viable. I think so.
Yeah, I didn't look at it before. Yes. By definition, it's a missed miscarriage.
It's non-viable, madam.
Yes, it should be non-viable pregnancy.
Your opinion is the same, doctor? Your opinion
yes.
Because
Yes.
this is what I'm reading with
yes,
you.
More than 25 mm.
No viable, exactly.
It's non-viable.
It's non-viable.
Dr.
That's
Mustafa,
right.
I want to know your opinion because this is your recall.
Yeah.
I think Mustafa, let us see what he's writing, but also he's writing the same.
No, about answer, you talk, yes?
Yeah.
More than 25, but first time I can't tell patient missed abortion. In all nice readings this one. Seek second opinion or repeat after 1 week.
Yes, you're right. Now I got your point. I got your point now. Yes, yes. So she should have a second opinion or a second scan after 7 days. Then you can say that it is
the
diagnosis.
Doctor, that is very correct point that Dr. Mustafa and even you are pointing out, but still the diagnosis according to the cutoff of the gestational cycle and according that the fact that there is no fetal pole, the diagnosis is there, is non-viable. But if they ask what is your,
she's right also, you know, she has a point.
Like another ultrasound management or second opinion.
You know, Dr. Mustafa, what doctor is saying that
more than 25, take a second opinion or repeat. Written clear in
management. I mean, what I understand from her that she's saying that what you will do, ask what you will do, then this is what you will do. You will seek a second opinion.
That is my point. Yes.
Yeah. But the diagnosis of
second opinion or repeat another ultrasound is there. The diagnosis is there. Yeah.
This is the management. I mean, this is what you will do next.
You not
That's
listen
right.
everything
That
what
is my concept.
Seema told. I not hear her too much, but after 1 week I will tell her it missed abortion.
Madam, the question here is what is the diagnosis?
Diagnosis. Yeah.
The question is what is the diagnosis, not the management.
That's right. That is my point
By
also.
definition, it is a non-viable pregnancy.
Yeah, you know, this is, people like us who solve this question. You know, it's not from the
If we see-
RCOG. We can change the answer. There is no problem if all of you agree. Mustafa,
Dr. Samira,
I want to tell you, because you did not hear me, that they have a point. You know, their point is, initially I thought also that because they are giving this gestational sac 27, but even it is not written in the guideline that if she's sure of LMP or not. It is written the definition of missed miscarriages if the gestational sac is 25 millimeter or more, an empty sac, or I think the fetal pole 7 millimeter or more. This is by definition a missed miscarriage, right?
Yes, yes,
Yes.
yes.
And this is what I was thinking, that this will be the answer. And if they ask management or the next thing what you will do, then we can
Yes,
say
yes, yes.
maybe I am wrong.
Yeah.
Mustafa?
Okay.
Yeah.
Yes.
I want to solve this one. Let me open the nice where it is written, or maybe it is written here. You are saying that we will not. Let me go to
Finally
the
diagnosed after 1 week or 10 days, according
final.
also transvaginal or transabdominal. But directly, I can't tell her missed abortion or confirmed first time.
Okay. Let us see, no problem.
But when took Dr. Saima, I can't hear her.
Yes, yes. You know, you might be right, but let us confirm, because some people are raising this point. This is for the, where is this one? Yeah, offer women and transvaginal.
Even in a previous crash course I attended with Dr. Ahmad, I answered him as finally diagnosed. He told me, no, repeat. I remember this one. It was my mistake with him.
If the crown drum length is less than 7, then perform a second scan. Okay. If the crown drum length is 7 and there is no heartbeat, seek a second. This is from, you took the, you took from here, right?
Yes. Yes, from here.
If the mean gestation sac is 25 or more, using a transvaginal and there is no visible fetal pole,
6 second opinion.
after the first, before making a
25
diagnosis.
or more.
No,
You
now
see.
I agree with you now, because I saw the evidence. Can everyone see this one? This one?
Yes, yes, yes. Perform a second scan.
Even, you know, I don't agree with.
Okay.
Yes. Don't agree with anyone.
Before making diagnosis.
Anyway, thank you very
Okay. Okay.
I may
So,
not agree with you.
yeah, we got
Now-
it now. Yeah.
Okay. Now tell me your evidence.
Perform a second
Or
scan.
everything, Mustafa, I will now, from now on, I will ask you for the evidence. Everything what you will say.
No everything, no doctor, no everything. I am student like others, but I try to do best. I try to do update recalls with my friends.
Different.
But to be honest, I give you my feedback.
Tomorrow
as
I will share all updates.
Dr. Mustafa is, I tell you, Dr. Samira, as a person that I've been following most of the records with Dr. Mustafa, he's a great. He wants to, he's very dedicated, and he wants all of us from his heart to learn. Honestly, he's very.
Why he's like this? Because he is very detail oriented.
He is, and he is very down to earth. He's very humble person as well.
Yeah, of course, this is about the personality, but I'm telling you why why his most of the answers are correct. I took from his recalls. I will not make my own recall because this is almost 100% correct. Not exactly 100%. There are some. He is updating his thing. If you find anything, and then he will update it. So it's almost correct.
Yeah, that's right. So if in the exam this question comes, so we will see is unknown viability, right? And we should confirm with another 1 week scan, right? If it comes to the exam.
We saw that there is an evidence. We saw the evidence that is
sure. Okay.
Before making a diagnosis. So what is written there? Before making a diagnosis. You should repeat it.
Okay.
Okay. So this is, I want to explain to you, I don't all the recalls here. This is not my basic idea. My idea is to give you examples that how you can read your talk article, how you can read your guideline in 5 minutes, how you can do your recalls and go back to the evidence, read the topic, because the next time maybe the recall might come from the same topic but some other scenario, like the trigger points for incident reporting. They can make several scenarios out of it. Delay in labor, oh my god, they are just, and many of us are making mistakes in this diagnosis of delay in labor, although it is written very clearly, but we are making mistakes. Dr. Mustafa, do you want to add anything before I'll close?
No, thank you very much, Dr. Samira, for your effort. Thank you so much.
Thank you for you to come and you added to my session 10 times more. Thanks a lot.
Thank you.
Thank you, madam.